All right. Well, thank you all for joining for this kind of hopefully interactive, fun session as well. And these are my disclosures. Shouldn't have anything to do with this talk.
I'm surprised there's not more of those disclosures, honestly.
Okay. All right. Well, we really are privileged to have three past presidents, three respected leaders within their fields and within their respective health systems joining us here, and all friends of mine. And I've learned a lot from all of them over the years. So I look forward to getting your thoughts, not only on some of the clinical things, but maybe from a system standpoint, from a training standpoint, and things of that nature as well. First of all, what do you wear in the OR? Your bouffant or skull cap, Ronnie?
Bouffant, disposable, because I can't keep track of the other one.
Okay. Dan?
Yeah, I wear the regular disposable ones from the OR. They're clean and I don't have to wash
Skull
them.
cap or bouffant?
Skull cap.
Skull cap. And Ken?
But just to make a statement, I wear a skull cap, reusable, sewed by one of our residents' spouses, and then I wear the bouffant cap over the top.
Whoa.
Whoa. All
Because
right.
Because I have to.
Belt and.
Yeah, I was going to say,
suspenders.
it's like you wear the N95 and the regular mask over two of them. Okay.
Oh, no.
Now do you, and you
Oh, sorry. I don't think this one's on. Is it on?
really close.
Shanu turned his off.
So, and you wash it every night per AORN guidelines, right? You take it home and wash the permanent skull cap.
That's a secret I won't divulge.
Okay. All right.
I wash the disposable and it works really well.
All right. So I thought about this. This was actually,
I'm simply here for comedic relief.
this is obviously a pseudoscience paper that I wrote, but it came out in a very timely fashion. I actually did the largest prospective randomized trial ever on clipping hair of the abdominal wall versus leaving it alone. And believe it or not, it's never been done before. And that's a gap in the literature. CDC actually says leave the hair alone is the guidelines. And so, but we often clip. We know that the study of razors and shaving is a no-no. That's clearly increased the risk of SSIs, but the head-to-head of leaving it alone versus clipping was never done. So we did that. I don't know if we have any former residents here because sewing through Sasquatch was not fun, as they called it, because Lord knows I wasn't in the room for that point of the operation. But we showed that there was no difference in SSI rates when you did it. So you clip, you don't have to clip. In the middle of the night, you come in there, you're trying to go, and then come in there with that. It's like, doesn't matter, just operate. Not going to change your SSI. But then this thing blew up and we got all of our skull cap taken away from us. And so I thought, well, if the skull cap is so bad, if there was one skull cap in that room, then it must contaminate everything. And so we went back and did it by preference on that prospectively collected data by independent nurses who assessed every wound of all those patients and reran the analysis based on what was the OR, what the headwear of preference of the surgeons involved. And of course, there was no difference. And so did the landmark SSI paper, largest prospective randomized trial in the country, make a blip on the radar? No. But did my study on skull cap and bouffant, it blew up. It was all over media. And it's actually even been cited even more times than the actual scientific paper has, I just realized.
So our hospital did have change, when that initial came out, they got rid of them all and we had to wear the bouffant. And then it must have been your paper, but they relaxed
was
it
one
and
of them,
allowed
yeah.
us now to do this. And
know.
then we're wearing skull caps again.
100 and some publications in literature. My contribution is I made the lunch lady hat optional. I can't believe that this is really what I'm going to be known for.
It was really good. I mean, we had been working a year and a half on a tire policy in the OR. You really helped a lot.
All right.
Seriously.
Okay, so this is a real true case. You get consulted by a hospitalist. Patient was in the hospital for pneumonia on the medicine service, and then intern decides to order one more chest x-ray before discharge. Of course, they didn't know that's not going to change the management. And they consult you and say free air. You go to see the patient, they're dressed, ready to go home, and just had scrambled eggs for breakfast. So what's your diagnosis? Any suggestions, any thoughts? I don't know if you guys can see it good imaging there or not.
So
Patient
just for
sitting up,
clarity,
dressed, ready to go
clarity
home.
for the panel, completely asymptomatic, afebrile, normal labs, looks great.
Yep, dressed, was getting ready to be discharged. Intern ordered one more chest X-ray, unindicated, recent hospitalization for pneumonia. Just ate breakfast, scrambled eggs. Any thoughts on the diagnosis? No high flow.
No. No gynecologic procedures done.
No. Look closer at that right
not-
side.
Is it
So-
chiliditis?
How do you say it?
I say
Chyliditis.
chyliditis.
Let's hear it. Hold on, I want to hear each
Chiliditis.
pronunciation. Chiliditis?
I say chyliditis.
Chiliditis.
Yeah, I don't know. I put it in because I was curious how to pronounce it, but yeah, so this was, that's what this is. That's colon up there. We usually get one consult of these a year for quote unquote free air. So not always
So,
what.
so I'll just point out one of the clues. I mean, it really is a little hard to tell on the right whether it is air, free air or colon above the liver. You always wonder, whether that could be colon above the liver, but it's interesting that on the left, you don't see any free air. You see the stomach as normal and there's no free air. So that is one clue and something probably to look out for if you're considering chiliditis.
Yeah, and then what
I'll
about?
change. I'll say chiliditis from now on.
What about the, anyone remember, residents remember what the difference between small bowel and colon on a plain film in terms of how you tell the difference? Where's those guys that were hitting it 310 yards into us every day yesterday? Remember, what's the name of it? First of all, what's the name of the line that goes a third of the way across, 2/3 at the most? Hostra, right? You can see one hostra. It doesn't go all the way, as opposed to the line that goes all the way across the small bowel is, you got like 3 different answers. What are they? No one remembers? Valvulae convenientes, plicae semilunaris. All right, so there's a little hostra on that one. So yeah, that's what that one was. So when you optical illusion, you see that chest X-ray and not everything. You got to put it all together because Ronnie's sitting here thinking, this is a nice Hawaiian beach picture, but in fact, this is not always what you'd expect. So just got to put it in context. Got to put it in context, Ronnie. You just can't be an isolated. This is why.
Context matters. That was in my presidential address.
Clinical correlation suggested. Is that still written on the bottom of
Photography.
San Antonio radiology reports? I always go up to them afterwards and I say, thank you. Thank you for writing that at the end of the report, because I was about to forget to correlate your film clinically with my patient until you wrote that in there. But anyway.
The
So,
critical finding wasn't, you were notified of the critical finding.
so I was, I grew up on a show called Quincy. I think most of them over here probably grew up on CSI, but it was based on a very famous forensic pathologist, and I did a forensic pathology rotation.
I don't know about.
Yeah, and when you read the book on who this character was based off of, when he would go to a crime scene, and I went to a few murder scenes when I was on forensic pathology, and ended up actually catching a serial killer when I was on that rotation. But what was the last thing they would look at was the body. When he would go to the crime scene, first thing he looked at was the ceiling. He's looking for clues and splatters and trying to put it all together. He'd always have the body, he said, but I wouldn't always have the scene. And so just like on a chest X-ray, when I was taught to read a chest X-ray, what's the last thing you look at on a chest X-ray? It's actually the lung fields, because everyone gets tunnel vision. They go right to the lung fields, and then they kind of forget the scapula fracture and some of these other clues. So, all right. This one, again, just for positive arrow sign here, you can see this cigarettes here, the lighter here, and the Goomba in the lung here. So, all right.
like a coup and contra coup.
What is this? What kind of hiatal hernia is this? You get called, patient got, put him in the answering machine. When I came in through the ER, CT, so stomach and the chest, they're puking. Start pulling on it. It's one of 4 types, right? There's 4 types. So I'm like, oh my gosh, what is that? I get nervous. I'm pulling some more stuff down. Is that dead? What is that? I have no idea. Is that an organ? I wasn't sure. So I try and pull a little bit more. That's not working. I normally don't, this isn't always the first move of this type. Oh my gosh. And then it came down. Look at that, Ken. Is this a true type 2? The GE junction it's where it belongs. Look at that. I think this is as close to a true type 2 paraesophageal hernia I'll ever see, which is where the GE junction stays in place, right? Stomach is above it. So it's kind of a fun repair because that work was done already. So anyway, but I don't know if they're supposed to have a sac like that. I don't know. I took it off. Let's see.
You just ripped something off there.
I did. All right, let's try this one now. As opposed to this, what's this one? Is this the same one or is this a different one? Well, this might be a different case. All right, so what kind is this for the residents in the room? First of all, what's that organ? Yeah, I put a little shark bite on there on that. Don't overthink it. What is that? Momentum. Whoa. And the colon comes out. And then keep pulling. So already, what kind is it? 4, right? And is type 1 + 2 = 3. So a type 1 + 2 is 3. And then if you have any other organ up there, it's type 4. So
Spleen gonna come down?
get the colon. I have had the spleen come out. I've done 2 with the pancreas up there. Slid up into the retroperitoneum. But now comes the chitlins. And now this just is like a clown car. Now they're just like, it just doesn't stop here. It's just keep on going, keep on. Nothing to see here, folks. Keep going.
Type 6.
Now you would have gutted this patient like a fish right now, Ronnie, right?
No, I wouldn't. No, I would have referred him to you
You
already.
would have docked the robot by now or what?
Yeah.
Dan?
No, you don't have to convert. Was that the question?
No,
Yeah,
I
you're going
didn't-
to robotically do this?
I
Look at
don't
that. We have time to go. It's still coming out. All the chitlins are still, all of the small bowels up there. Unless I just keep grabbing the same loop over and over there, but
Which is likely.
it's possible.
Try raising the head up and, let the bowels just
Yeah.
fall out.
Are you a mesh, no mesh guy, Ken? Big hernia, first time like this?
It depends what the curl look like when you pull them together.
So the integrity of the crura will make your game time decision.
Yeah, so I tell the residents that if it looks like an upside down teardrop, you got a reasonable chance of getting it together. But if it looks like a baseball, the posterior crura are going to be very difficult to pull together without tearing it. So you either have to do a release and patch the release incision on the diaphragm. I've also started to put mesh above the crural closure. So it's actually in the mediastinum and not
Oh, look.
abutting the wrap of the stomach or the esophagus below the
Yeah.
diaphragm.
So this has become a newer repair. Where, and to what Ken's, Dr. Mariama's point is, the recurrences actually take place up here. I always thought that I'd put, I always dictate how many stitches I put in the back, in the posterior. Is it 1? Is it 5? Is it 7? Whatever. And then 3 years later, they come back, the hiatal hernia is this big. And I'm like, even I didn't leave it that big when I went in there. And so I go back and look at my op note and by golly, they're still there. However many, the stitches don't tear through. It's just that the tissue is attenuated and kind of opens again. And so I think we've been putting the mesh in the wrong location. So the 2 prospective randomized trials in the country, or one in the US and one overseas, that showed no difference in 3 and 5 year recurrence rates. It's because we're probably, it could be that type of mesh we're using, or it could be our location. So we maybe need to be putting more mesh over here on this side, like you said, Ken, because it's up and to the left is where that recurrence tends to occur. So
Are you using a bioabsorbable mesh there?
that is an absorbable synthetic.
Absorbable.
Absorbable synthetic, BioA.
What does that look like when you go back in 6 months?
It looks like neofascia. It looks you can't see it. It gets replaced by scar. Now, if this patient comes in the night, you're going to tuck this in, Ronnie, San Antonio, because you've got the doing the knife and gun club. You're going to stick an NG down there and wait for a minimally invasive surgeon to show up, or do you just take it and go?
So I think the future of general surgery is diversity. And I think that that includes the surgery. So I think for complicated paraesophageal hiatal hernia things, I'm gonna involve our people who do that during the daytime, and we'll make a decision on what to do. I think the latest data is that a lot of these are chronic, and so it'll based on the clinical condition of the patient and make a decision on that.
All right. And then are your bariatric surgeons your foregut surgeons, or is your place large enough that you slice out your foregut surgeons from your bariatric surgeons?
They're in the same tribe, although they've sort of divided themselves up into a metabolic bariatric team and a MIS.
Dan, what about at Cedars? You can do this in the middle of the night, or is this a tuck-in with an NG?
No, I would agree with Ron. Involve the people that are expert to do it. If there's dead bowel or something, then it has to be done right away.
Yeah, which is hard to do. So you do endoscopy. Mucosa goes first, right? So you're going to do endoscopy as your triage to decide whether you can tuck it in till your MIS team does it in the morning versus go.
Well, there's usually indications that you need to go sooner or later, and you can go by that.
Anyone do push endoscopy to try and decompress these while they're looking at the mucosa? Raise your hand if you've sort of done that technique to try and reduce it to buy you some time, or anybody doing it? Dr. Grover, did I teach you that? Hopefully not. No. Okay. Does it work? Gotten you through it? All right.
So I would say if the patient's sick enough and symptomatic enough in the ER in the middle of the night with this, that you think you need to do endoscopy to decompress it, I would probably consider going to the OR if they're that symptomatic. So I think if, you look at the whole picture, the clinical picture, their white count, if they have a lactic acid drawn, get the chest x-ray, and it depends what they come in symptomatically with. If they come in with severe pain, then I think you go to the OR. If they come in because they just feel like food's getting stuck and you get an x-ray and their white count's normal, I wouldn't go in the middle of the night. But I think if you're going to do endoscopy, you ought to be doing it in the OR in these patients.
Yeah. All right. Let's see. All right. So you go in and then you
Is
see
that,
this.
is that what my liver looks like?
What's that?
Is that what my liver looks like after last
After the
night?
4 bottles of wine you had in my suite last night, I think so. So what if you do this? Are you going to go in there now? You're going to go fix one of these and you get ambushed. You didn't look at the astute intern's very detailed history and physical that said they drink 8 glasses of, something a day for 30 years. There's a little, that's for you, Ronnie, in case your vision's a little bad, we can let you.
It is bad, but yeah, even I can see that.
So do you abort? Do you biopsy that? You stick a needle in it? Do you true cut it?
Sorry, what are you in this?
Yeah, what are we
for?
in here for?
Hiatal
Since you got
hernia.
us in there.
Elective
Hiatal
hiatal hernia.
Oh my gosh.
What would you
Surely
do?
they had a CAT scan that showed that.
Pan scan, that's all you do, right? You guys do it.
I know y'all are all against CAT scan. Yeah, it's what you say here, and then you really order it all the time.
Endoscopy and an upper GI.
Everybody's against
is-
it in a meeting. Nobody's against it when you're,
Upper GI
trying to
and
explain
endoscopy is
what you're
all I
doing.
need for this. I don't know, I don't need a pan scan. So what you're gonna abort?
No, I mean, you've already made put the person under anesthesia and stuck the scopes in, and now you're there. You might as well do what you came to do, as long as you don't cause injury or bleeding. I wouldn't leave the liver alone. I don't think you need to biopsy it.
This is real time. You can see how long I'm staring at it to decide myself.
Yeah, exactly. I'd be like, they better have a pretty good reason to have that paraesophageal hernia fixed right now.
Ken, you stick a needle in it, biopsy it?
So I think it depends what kind of hernia you're there to fix, right? So if this is a sliding hernia for reflux, I might reconsider doing it at that operation simply
Comes the
because
biopsy right now.
you're gonna take
Here
down the
comes the
short, you're gonna take down the short gastrics,
The unintended liver biopsy.
Yeah.
dissect out the distal esophagus. And so I'd want to know for sure that this person doesn't have portal hypertension as well, since you're going to disrupt collateral circulation.
So my point is.
But I would actually do a needle biopsy
Yeah.
if you're there.
I think you're there. I think you do.
Safer you do it while you're looking at it than the radiologist and then
So I
2
didn't
days
realize a
later.
lot of my Bertie colleagues are doing, with so much NASH, they're doing routine liver biopsies on all their patients. And then I'm scarred because coming from when I interviewed at the University of Chicago 21 years ago, I turned it down to go to the Wisconsin job at Gunderson, is one of the surgeons had a patient exsanguinate in the recovery room from a liver biopsy. So I was spooked ever from hearing that story. But how many people do routine liver biopsies if they're doing bariatric surgery? Just do it. Some people are, and so it's kind of interesting. My game time decision here as well, I'm worried about the varices. What's the GE junction going to look
Yeah.
like?
Mhm.
So I'm going to lift this up and take a sneak peek and then make a game time decision. But obviously it's not fun to, it's a little hard. Here we go. And then,
This would be nice to have looked at that CAT scan ahead of time so you could see if there's varices. I know y'all are all against it, but it'd be really nice to look at a CAT scan to see what those varices are.
but we have a fibroscan, right? Ultrasound is what you're doing now to make the liver diagnosis. You can't tell that kind of marbling on your CT scan. Oh my gosh.
Really, come
You're looking,
on.
you're just looking, and there was no grade 4 liver loss of it, just to let you know, Ronnie.
That's coming next here.
Yeah, when I take,
And let me tell you, it doesn't take a grade 4 to cause a problem here.
yeah, but to your point, you see how I have that up there? I have a friend and who invented a magnetic one of these to make it atraumatic. Because I have gone back, we have had one liver lac on a gastric bypass that came in, and the radiologist actually called me and said, "Is this a car accident?" I was like, "No, it's a gastric
It's a
bypass
grade
patient."
5 probably.
But it had gaffed the liver there, So how many of you use this liver retractor as a Nathanson? Yeah, love it, don't you? If used properly, if not, it's a weapon. It's like a harpoon. But the other spaghetti retractor one is, I'm not a big fan of. Plus, it's near your left hand, and I don't like it for your left hand for that banging into that thing. So this one's up north, but yeah, if used improperly, and I've seen it. And then I've also come back, like to take a gallbladder out. By golly, if that line wasn't left in there, and the left lobe was like a little potato chip turned into a shrinky dink, and I had probably due to venous congestion dinged it. And I've seen that imprint of there. So now I give it a breather. Whenever I see that little edge turning purple after a while, if we're down on the JJ, why do I even need it up there? I'm not up there, then I'll just unhook it or give it a little breath, because there are some other more atraumatic ones that are on the market now, but okay. All right, patient comes in, diagnosed, delayed gastric emptying. You've worked it up, gastric scan, whatever, maybe they had a Nissen fundoplication by me in the past and I took out both their nerves, whatever the etiology is, they have delayed gastric emptying. And having had the privilege of only being in that American Board of Surgery oral exam room twice in my life, once to take it and then once to give the exam, I now know what are the acceptable answers for delayed gastric emptying in terms of treatment. But what would be first line for you, Ken?
So, so this is someone with diabetes, non-diabetic, prior surgery, no prior surgery?
Yeah, it could have been a good question. Let's say multiple previous foregut procedures and the vagus nerves have been bagged and tagged. That's your presumptive diagnosis.
So the vagi are out.
Presumably, yeah.
Yeah, so unfortunately, I think you can try Reglan, and there's not much good out there that helps with stomach emptying and delayed gastric emptying. So I think if you're faced with possibly doing something surgical, if the delayed gastric emptying is so bad that now they have bad reflux and regurgitation of food, severe gastric distension, it's a miserable way for them to live. So I think you're going to be faced with doing, looks like what you might be doing here.
Yeah.
Right. So some kind of emptying procedure.
What about Botox? You give them a test of Botox of the pylorus?
Yeah, I mean, it's worth a try. We've done it before and it's actually reasonably successful. I've seen people's emptying time cut in half if you do Botox. And it's really, unfortunately, with both vagi out, you're not going to get better, you're not going to have motility. So it's probably not going to work as well. If it was diabetic gastroparesis and you think you have some stomach peristalsis, then it's worth a shot, I think.
Yeah, I think when it works, it gives me the pretest probability of it is good to know that I think I'm going to help them more if I go. But if it doesn't work, it doesn't mean the pyloroplasty still won't work. It's because maybe they just didn't inject it in the right place and things like that. So, and then just for the record, Ronnie, this is not a pyloric exclusion procedure. Just to let you know, this is. I know.
That's what I thought it was. I mean,
But-
it looks not very pretty, I'll just say, but,
Yeah, thanks. I'm right here. I'm right here.
oh, sorry.
So, Botox, pyloroplasty, but actually, oral board exam now, actually subtotal gastrectomy is becoming more as an acceptable answer as well. I'd rather start with this. You burn no bridges.
Yeah.
Obviously, you're swinging for the fence if you're going to do a subtotal. How many people use, their first line would be, surgically speaking, would be a lap pyloroplasty? Yeah. How many, raise your hand if you've done a subtotal gastrectomy, Roux-en-Y reconstruction for profound delayed gastric emptying. Didn't work? You took it out, the stomach? What, did you leave them a small pouch? You left them a decent pouch. You did, and they still didn't get better. What about doing to an esophago J then?
Oh my gosh.
All right, so yeah, then what do I do? Oh yeah, there's that, then where am I at here?
I don't know where you are.
Oh yeah, then I stitch it closed. The first one is always kind of hinky, but it's never leaked, but I can never get that one perfect, like right there.
Yeah, look
It
at that
always
corner.
looks
awful.
Looks awful, but it always heals. See, I'm trying to fix it because you said it, you commented, and I'm trying to move it up a little higher. All right, where am I at now? So anyway, close it up, stitch it better. All right. Okay. What do you think? Have you ever seen this anatomy, Dr. Stewart? The beauty of bariatric surgery, it has resurrected an entire field of
Of internal
radiologic
hernia
in
repair,
terms that,
exactly.
that you had thought you had once killed, because back in the day, when patients used to come in with the perforated ulcers and we're doing those with a frequency that we're used to doing appendectomies, and then the PPIs wiped that field out. The afferent limb, the efferent limb, the roux limb, all of this became gone by the wayside, and then field of bariatric surgery resurrected it again. I'm old school and still go retrocolic, retrogastric when I make mine. So there's that mesocolic defect. These are the 3 defects that you worry about. But crampy abdominal pain comes in waves. You got to go to the OR. Take a look. I tell the patient, I hope I'm wrong. The worst thing I do is to say I'm wrong. And you wake up with, and I didn't have to do anything. But if you're sitting on this, it can be pretty devastating. And this is, where's Dr. Schreppel? So one of our former residents from over 15 years ago doing trauma rotation or fellowship at the name called me, told me about this case. So 10 days sitting on this patient post-gastric bypass with abdominal pain.
How many CT scans in the 10 days?
Good question. And they just said there was something wrong with his intestines. They didn't know what, and then shipped him out. And by the time he got, when Dr. Schreppel was on call, was in septic shock, and young guy and surgeon in training, and opens up and sees this on a 28-year-old individual, and then runs next door and gets a consult, and they said, you're done, close him up. And so completely a true failure to rescue, and something that clearly, like they said, index suspicion, 20% of imaging studies, even Ronnie CT is normal in this situation. And so never let the skin get between you and diagnosis. So get in there. I always ask when the resident or trainee calls me, is I say, what's the excluded stomach look like? Am I seeing fluid in there? because that could be, that's a distal obstruction path, you know, doesn't mean you're vomiting, it goes up the other way, biliary pancreas starts to fill up your excluded stomach there. And then there's something going on here, some haziness and some distended bowel. So then we're back to who's going to do this case? Do you have a Burgett call schedule at San Antonio?
We do.
Yeah, you have to be accredited for MBSA equip accredited
That was
centers.
a trick or something? You're tricking me?
What's that?
Is that a trick question?
It was, yes. But who would do this on call? This is your acute care surgeon? Are you going to call the bariatric surgeon? The bariatric surgeon says, do it. I've got 4 cases on tomorrow.
I mean, they usually wouldn't tell me that, really. I don't know the truth.
I'm going to talk to him after this. I'm going to call, I've got his cell phone right here. Dan, who does this?
Well, similar to San Antonio, we have bariatric call, you know, the MIS call and fellowship as well. So they're going to be the ones doing it. But we are very aggressive. If you're concerned about pain, like, you know, in a post-op setting for a hernia, they're going to take them in the middle of the night right away.
And
I'll just say, you know,
the
we,
acute care general surgeons, trauma surgeons on call, they're going to, maybe, are they going to gut them like a fish? Nothing wrong with that if they have to do it that way.
what do you mean get them like, you mean like a laparotomy incision? Is
Yeah,
that what
yeah,
you-
the
oh.
morbidity, I don't know. I haven't done
Oh,
one in about
yeah.
20 years,
That's
so I don't know.
like- So you're like, you know, you basically talk about how important it is to really be suspicious and have an early diagnosis and do all, then you throw the gutted like a fish thing, like making people afraid that they have to make an incision. They
No,
have to
but
make an incision. Just
It's the
make
one operation where the,
single port surgery.
this is the one. Same thing as where this.
Scary, I know, very scary.
I know.
And hardly anybody
You
survives
gotta do
it
a
either. It's just like.
fellowship in it now. You got to do a fellowship in laparotomy.
No, but I
Um,
was gonna say, you know, in our institution, you know, depending on what's going on with the metabolic bariatric team, if they want us to start, we'll do that. But I really do think it's helpful to have the people who are the most knowledgeable be involved.
I mean,
So
I've done this
similar-
for 20 years. It can be very confusing anatomy. And actually, I've had to do a when it's over 360-degree twist, when it starts to get to 720, the torque on the ball, I can't. I have to go open and just get 2 hands in there and flip it over. So
720, that sounds like one of those Olympic events on the
yeah,
skateboarding or snowboarding.
yeah, it happens. Then just refix that. Okay. All right, here we go.
Lap call.
Oh, wait, this is a different case. So you had a lap chole, do a Hassan technique. Patient comes in 3 months later, transition point near the umbilicus. The chief, it's on the chief service. Chief says, we got to go. It's midnight. You're like, seriously? Okay. They're going to go home in the morning, but I'm going to go back to work, but we're going to go ahead and see what this is like. Yeah, so here we are. Would you do a Hassan cut down right over the transition point? But I didn't. Obviously, I would do laparoscopic, flank it, sneak up on it, see what's going on here. And then some adhesions there. There's loop of bowel stuck there. What else is going on here? It's like what would be a Richter's hernia, but there was an obstruction, a stricture point there. At this point, Dan, what are you thinking? Just go open, be done with this? Take that last bit of that adhesion down,
You have to get it down. and
persevere.
You have to make sure the bowel's, you know, viable and all of that, and that it's got a patent lumen. So you've got to take it down.
You got to persevere. It's with the last 7 Ps, persevere, be perseverant,
Okay, so let's see.
and be patient.
Look on the backside and see. Still,
It's like worse than a CAT scan, like zipping through there.
so now still like there's still one loop of bowel stuck up in there. So once we get this out of here, we're going to put mesh in there. If it's not a full thickness strangulation, or you just stitch it closed. How many are going to put mesh in? Nobody.
What kind of mesh?
Well, you got absorbable synthetic, you got biologic, you've got lots of options if you're going to at least make that decision.
So I think it depends how big your defect is. If you can reduce this and you don't have to resect bowel and it's 2 centimeters, I might put in a couple of transfascial sutures, maybe put an absorbable mesh on the inside and explain to the patient afterwards, you might have to come back for a formal repair.
Yeah.
If you have to resect bowel, I would definitely not put non-absorbable mesh in there.
All
But
right.
it just depends.
Is that
That
bowel
bowel
okay?
looks
I
like,
don't know.
That,
doesn't look good.
see, look at that bowel. You need inspected, or you're going to take that patient to the scanner now to see what that bowel.
Oh my God.
Right.
I hadn't seen a single open picture in this presentation either, but I mean, whatever.
Well, yeah, so I would resect that. You're going to laparoscopic, I got to make an incision. You're going to incision through that sham Hassan closure that didn't work,
Sham.
and then exteriorize it. And all right, because now I'm fighting with the chief resident. She says, well, this is my patient. And I'm like, really? Okay. Well, what do you want to do? She's like, well, I said, well, because I do this laparoscopic all the time. It takes me 7 minutes to do it. Anastomosis of the small bowel. Chop, put it together. Now I'd have to take the specimen out, probably through that Hassan. So the whole point was, well, let's open the Hassan, let you do it. If that's not in your comfortable skill set yet. And then we did that. And of course, did primary suture recloser. And then of course, that thing lasted 6 months and then needed another formal repair of the ventral wall. All right. Now, biliary colic, 35-year-old, stones, no ductal dilatation. Cholangiogram, yes or no? Ken?
I'm not a routine cholangiographer.
You're not. You're selective. now.
Selective. And then I use ICG as well to identify the anatomy and intraoperative ultrasound if necessary.
Dan?
Yeah, similarly, I've converted. I used to do them routinely and just partly for benefit of resident teaching, as well as safety of knowing the anatomy and all of that. But it's really not cost effective. And if you're comfortable with the anatomy, you don't have a need to do it for a question. I don't do it anymore.
All right.
So I'm selective.
All right, Ronnie, don't say Roux y hepatico J.
No, we have a protocol guidelines that basically based on LFTs and clinical presentation. If I think can't remember, it's like 2.5 times normal. It's that we'll do a selective cholangiography. Otherwise, no.
I do like the phrasey, one of the contributions, the Southwest Surgical Multi-Center Trials Group, that we looked at that data and we had the cutoff of bilirubin of 4 for going for it yourself, like versus the pre-op ERCP. So I thought that was a good tangible takeaway from this society as well. Again, based on institutional expertise and, do you have the infrastructure in place and the toys to do a laparoscopic transcystic exploration. But it just depends on the data, on the cholangiogram. I mean, sometimes, Ronnie sees a duck. Dan
I
sees
saw a rabbit.
Dan sees a
actually.
rabbit.
First time I
But
saw
it's
a
just a
rabbit.
matter of how you want to interpret that data on the cholangiogram.
It's maybe 2 hot dogs. See him? You see it? I can see him. The bill.
Do you talk about common bile duct injury, or do you give them an actual number, Ken?
When I discuss it with the patient,
Yeah.
I don't give them the actual number and then unless they ask, but I tell them that's one of the most feared complications of a relatively straightforward operation. So just know our job is to not have that happen. So we might do imaging at the time of surgery.
Yeah. Dan, you give them a number, or do you
Yeah,
just say there's risk of injury to other structures and organs when I'm in there?
I don't throw numbers around unless they do ask, but so similar to Ken.
Ronnie?
I mean, usually somebody else is doing the consent, so I'll just say that right up front instead of acting like I'm doing the consent here. But I think I wouldn't. I think I explain it that it's a very low risk, but the most serious complication, and don't give a number unless they want a number.
Isn't it, those of you who are of the military background, isn't it, you go to prison in the military if the person who does the consent isn't the one who does the case? I've been told that. I don't know, but
I guess jail time. is where
Leavenworth
I'm
for
headed.
you, Leavenworth, Ronnie, if they were in the military.
There you go.
All right. So how many give a number when you do it? this is the one time I give a number. 0.4%. Then I translate it and say about a little less than 1 in 200 chance is what I quote. Anybody else? Is it my? Yeah, 0.5%. Yeah, 1 in 200 is kind of put it in perspective.
So it sounded like a real dinosaur here, but it would be 0.2 if you were doing them all open, but I mean, whatever.
Oh, gosh.
That's the number.
Yeah. All right. Then the patient on social media, we've heard a lot of it says, if you have critical view of safety, you will never have a common bile duct injury.
Never say never.
All right.
Yeah,
Okay.
never say never.
All right. That's when you take a slip of your coffee and hold it up and then slowly put the cup back down when the patient asks you that. All right.
Is that your cup? Do you really have that? You don't have that cup.
No, but it's very popular. All right. Dr. Potts was talking in his presidential address about training, supervision, and how we need to give them a little bit more leeway, confidence, experience, et cetera.
Autonomy.
Yes. And trustful professional activities as we progress towards this level of. So what's the critical portion of the procedure? Dr. Stewart was present and available. What's it at your hospital? Does that mean you're in San Antonio, you're in the state, you're in the lounge, you're in your office, you're in the corner of the OR?
No, you're present in the operating room. And I define what I just write down exactly what those critical portions were. It's up to me to define it, and I write them down. I was present for these critical portions.
Dan, what's the Cedars-Sinai definition of present and available?
You're there. So your obligation is to make sure the patient does well, gets through the operation safely, at the same time teaching residents how to act independent and they sometimes struggle. So it is a balancing act with laparoscopy. You know, often I'm just can sit in the room and watch and know when to intervene or not, and before they do something. So, and even in open operation, you have to be there to prevent something that might go wrong before it happens. But you also have to, you know, allow some autonomy and teach. So you need to be there for the portions that are going to put the patient at risk. And that is going to be different for every operation.
That's true. Ken, policy?
So I think the critical portions are determined by the surgeon officially, right? I think it's up to the individual surgeon. So I always tell people that the critical portions of the operation are the ones where you're not comfortable not being there. So if you are one of these people that needs to be there from skin to skin, then it's critical that you're there, because if something goes wrong, those are the situations where we're quick to fix blame on somebody else. So, you know, I think you have to be there for the parts that you feel are critical, whether that's all the way through or when they're doing getting the critical view of safety and putting the clip across the cystic duct, whatever that is when you should be there. I'm in the room for the whole operation. I do feel like it's my responsibility to be there for induction and extubation, because that's when things go bad that are out of your control, really.
And then
I would agree with Ken. You know, it's going to vary not only by, you know, when the surgeon's comfortable with, but the level of resident. So I might, you know, leave and let the chief resident close. That's fine. But, you know, an intern, you're not going to leave and let them close and worry about, you know, whether they catch the bowel or not. So, and then things have changed in terms of us having to be there at the beginning of the operation for the timeout. It used to be that, you know, you could let the residents start. Now you have to be there at the very beginning of the operation. So essentially you're there at the start and determine what to do from there based on the residence level, the operation, and your comfort.
well, we had the goose that laid the golden egg and we ruined it. I'm not going to name the institution that kind of got busted and changed the course of this for everybody in the country. But the irony is we're here in Hawaii, but I don't know if you know the story that the surgeons were here in Hawaii. Golfing.
That I know.
Yeah, when the residents were doing the cases and saying Dr. Blank was present and available. That was
So
1997.
the surgeon was here in Hawaii when the case was being done?
Yeah, back.
Oh, I think I do remember.
Yeah,
that
so
story.
that's probably a little bit.
Brother, that's a pretty liberal interpretation.
All right,
there.
you're gonna let the trocars place? You're gonna sit in the corner and let them put the place the trocars?
Similarly, it's, you know, you've worked with the residents for 5 years, and if you're comfortable with them placing it, you're not going to let them place it if you've never worked with them before or know them. So it depends
Okay,
on the
Ronnie.
level of the resident.
You're up, buddy.
What,
No
warning.
phones, no phones out. Well, okay, great. Right
Warning.
there.
Hey.
Phone, no, I was gonna say the next slide. Just don't take the video of the video that I'm about to show.
I wasn't gonna take a video.
All right, so you're sitting in the corner. You say, go ahead, start. And they put the trocar in. Bam.
Yeah.
All right, walk us through it, Ronnie.
Looks like to me it's time to open there.
So, yeah, so let's hear it. What do you do?
Open the abdomen
And,
through a single port
and,
and put your, do immediate digital control, proximal distal control, and whatever else you need to fix.
proximal disc, you're not gonna just put a, I'd put a
Immediate
lap pad
digital-
in and just
immediate
hold
digital
pressure, talk
control.
to anesthesiologist, tell them,
All bleeding can be stopped with direct pressure. So yeah,
and,
You know, this is something that it's so rare and it happens, but you need to think about it. So, you know, you asked me whether to let the resident put the trocar in or not. In almost all cases, I've talked to them about like, and I've shown them CT scans with the aortas right up to the abdominal wall and make, you know, I talk about that a lot because you sure don't want to have this happen. So, you know, one thing is to talk to them about it, other techniques about pulling up and not putting it in too hard, all that stuff. But once this happens, I'm with Ronnie, you better stop the bleeding now. You've just converted I knew you'd have a trauma case.
I told you, yeah, I know. This is actually,
Now
like
there's
our-
a trauma
yeah.
case and you got to stop.
is this
stop
like the most common cause of trauma in Gunderson? I mean, what's?
no, this was, I just want to thank you for giving me this video of one of your lap colleagues, Ronnie. I appreciate you.
You need
By the way,
to,
this is now the critical portion.
Yes.
yeah, I'd say.
So,
So you have to stop the bleeding. That's one. Another is don't forget about, you know, the need for possible transfusion. And third is, you know, having access. So do you have access or do you just,
Yeah.
or does the anesthesiologist have a teeny IV in and you don't, and now you're really in trouble? You don't want them to bleed to death. So all of those three things have to happen simultaneously.
So I will say this, that the one thing I have noticed, having done lots of laparoscopy for the last almost 25, 30 years now, is this is the one place where when you look across the table, you know if that person is going to be able to handle this, do something about it, or they look like a deer in headlights. It's amazing how many times blood makes people absolutely paralyzed in laparoscopy. So I would say this, you're definitely going to open, but the first thing you want to do is you want to have somebody give you a sponge, quickly put it in the port, put some pressure while you open, because often the team's not ready to open immediately. You think they should be, but when you say, hey, give me the knife, they're like, oh, well, we're counting the open instruments right now, right? And so you have to be prepared to how you're going to handle this until you can get that knife and open and put a lap pad and put your fist in there to hold pressure on it. But so it's amazing how people do get paralyzed when they see blood laparoscopically because it's magnified, right? And it's
Yeah.
very dramatic, especially when it shoots the camera.
Yeah.
Luckily, this one didn't, but
I mean, I know that's not what we're talking about, but another time is so this is, even though it's people talk about it all the time, is emergency tracheostomy. So an emergency cricothyroidotomy, it's another thing that makes people, never mind. I mean, you can't talk seriously here.
all right. What's your leadership style in that situation? You're gonna be master and commander, calm, cool, and collected like Dan is here, or
yep. If you're
something
talking to me,
else?
if you're in the OR, you got to be the leader in that situation. If you panic, the whole room turns into a
Just relax, stop
Yep.
the bleeding.
stop bleeding. Pressure is still the
Good
best. first.
situational awareness of maintaining the
Is
room.
that
How
why
can
we
you
didn't
have a
win the other
serious-
day?
How can you have a serious panel discussion with these slides? I mean,
All right. What about the
what is
debrief?
this?
Teachable moment with the trainee? What are you gonna do? How are you gonna pull that trainee aside? Because they may never come back to the OR ever again.
Could have been the faculty.
As
who did
opposed
it.
to the ones that are like, screw you, this is surgery, this stuff happens. I mean, how do you handle this after the fact with the trainee?
It's important, and I think you should, everyone is a little different, but definitely that person is going to be affected by this, and you want to, have a discussion that complications do occur and will occur, and go through how to deal with it. It's could be very devastating, and you want to also talk to the whole team.
All right. Who knows?
Forgive and remember.
All right. You should recognize this person, Ronnie. He
Is
was
that
your
Sean
senior.
Kuthari?
He was your senior
Is that you,
resident.
Sean?
He was your senior resident, Ronnie. This is Lariche of Lariche syndrome. Every surgeon carries within himself a small cemetery where from time to time he or she goes to pray, a place of bitterness and regret where he or she must look for an explanation for one's failures. So that's Lariche. We all go there. I got a little small. Fortunately, it's small, but I have a cemetery myself. And then the impact that this has now, this sort of second victim thing is becoming very real. So this just came out this month in terms of the emotional impact of such complications. You can see the variety of feelings. Of course, worrying for the patient is number one. Guilt, crisis of confidence, and then what they felt in this survey of what they desired. Most was the structured debrief, and then just a culture of openness available for counseling and mentoring, and what happened afterwards. You can see where we go through that phase where you don't want to let the trainee do something for a while. Can you get back on your surgical horse and ride? And so something to be aware of, as I know all three of you are highly respected within your practices and have to look out for those folks as well.
So we're actually studying this. It was our chairman's observation that, occasionally have the intraoperative deaths that are unexpected, and that they're not as infrequent as you think. If you look over years, there are a number of them. And so he's working on prospectively he put together a team to do an immediate debrief, which is sometimes difficult in the middle of the night and all, but a debrief with people that follow a script of things that have been already pre-designated. And so he's actually doing this so that, and they're trying to see if it's going to make a difference. But the team certainly has all those things going on that you mentioned, and this is a proactive method to intervene right afterwards.
Raise your hand if you video, kind of let roll film during your cases, just kind of pretty routinely. How many of you never video? You're always worried about the medical legal ramifications or whatever this new law is where they can see things right away. What's that? Don't see the utility. I do. I'm pretty liberal because one, I like to submit videos to national meetings and learn from other people from doing that. I call it the Zapruder effect. Where you're rolling film, Ronnie, you never know what you're going to catch. And so I had just come back from this meeting years ago where we had been talking about cases, and Ken had mentioned in his mentorship role, like a patient had perforated the Heller myotomy, the resident, and you said, fix it, and you let them fix it. And you got to let them, sometimes he or she get that confidence because this is going to happen. This is called, real life, real surgery. And so here I am doing my first laparoscopic median arcuate ligament release, and the resident, we were done, and the resident, as an afterthought, went to put a clip on the inferior phrenic and avulsed it, and we went from waking the patient up to I thought, well, I'll let him try and get himself out of trouble, because I'd literally come back from this meeting and my mentor Ken had said you sometimes got to love, and in retrospect you can see it was a flaw. The clip was malaligned, it wasn't going to work anyway, and he was nervous and he split the celiac trunk open. He's a very gifted surgeon, by the way, and it was crash open, supraceliac clamp. Here we go, after we were already done with the case. And so tragic indeed, but unfortunately, if you want to see what audible bleeding looks like, I had it there. Well, I'd like, in the interest of time, I want to congratulate all of you for your expertise, your willingness to share.
Is that from Texas? I mean,
Yeah.
where is that from?
So, and especially for the video footage that you provided, Ronnie, thank you for that. And so, but in all seriousness, not only are they respected colleagues, they're truly my friends. And I really have cherished the friendships over the years, particularly here through Southwest. Thank you very much.